everyone. Today we are here to discuss a very important topic, that is role of ultrasound and beta HCG while making a diagnosis of ectopic pregnancy. So we are having with us Dr. A.B. Vani sir, who is Director and CEO of Team Bilmed. Good evening sir and welcome to the session.
Thank you.
And I would like to request sir to take over the charge of starting scanning techniques and how to scan properly so that we never miss a ectopic pregnancy.
Okay. So today we are going to discuss a role of ultrasound and beta HCG in ectopic pregnancies. Now see, first of all, we should have a good theoretical knowledge to understand the ultrasound picture. Not only the practicals will do, we should have a good theoretical knowledge first, then only we can interpret whatever is on screen. Point number one. Point number second is that not only ultrasound will make or exclude a diagnosis of ectopic.
Yes.
We should have a second eye open also. That is the beta HCG. So that is why we are going to today discuss ultrasound as well as beta HCG to make or to exclude a diagnosis of an ectopics. Because ectopics are not very rare, and with these these ARTs, we are now having an increase in ARTs in ectopics also.
Yes.
So it is accounting for about 1 to 2% of all pregnancies. It means that if you will scan 100 patients, you will expect 1 or maybe 2 ectopics. So it is not very rare and it is increasing day by day.
Yes.
That is point number third. Point number fourth is that it is having a high mortality. I mean the maternal mortality, and the maternal mortality is as high as 15%. So here you have to make a sure shot diagnosis that this is an ectopic pregnancy. You cannot miss an ectopic pregnancy. That is the point.
Yes.
And the fifth point or fourth point, whatever, is that you are the final judge. You are being a gynecologist. You are the final judge. It is you who have to decide whether this is an ectopic or not, because sometimes it comes with a report of query this thing, query that thing, query that thing. The patient will not ask to a radiologist what to do.
Yes, sir.
Patient will come to your clinic, madam, this is my report.
What should I do?
This is plus minus. This is query. Now you take the charge what to do. Then you should have a good interpretation knowledge, not the ultrasound knowledge, interpretation knowledge. By interpretation, I mean if it is looking on ultrasound this and beta HCG is showing me this, what it actually means.
And we have to decide management also, whether we should do it conservatively or we should open the patient surgically.
So you should know when to rush to OT.
Yes,
that's
sir.
it. Because it is having a very high mortality, 15%, more than 15%, I will say, maternal deaths are reported with these ectopics. Now, the point here is that, first of all, there is something which is called as, pregnancy of unknown location. Not all query ectopics, try to understand, not all query ectopics or whatever the report is coming over there, plus minus ectopic, query ectopic will be ectopic actually, because it is possible that it is a pregnancy of, unknown location, PUL. That means you may be dealing with a very small gestational sac. When I say small gestational sac, I say intrauterine.
Yes.
Intrauterine, not ectopic, which is not picked by your ultrasound. So then the report is coming with empty
uterine cavity.
Empty uterine cavity. And you are straightway thinking all lines of ectopics. But maybe it is a very small gestational sac which is not
about
picked,
to come,
which is about to come, which is not there on ultrasound today. Why?
Yes.
Because when you are expecting a 5 weeks gestational sac to come on ultrasound, it is possible that you may be dealing with a delayed conception. It is actually 4 weeks or maybe a 3.5.
We do have such patients
with
us.
Now see, the point here is that patient will not come to you, madam, I am having late conception. Patient does not know that she is having, even you don't know.
Yes, sir.
Even you don't know that patient is having.
That is what we have to find out.
Right. Now it is possible that you are dealing with a small gestational sac which is not picked on ultrasound. So that way, don't straightway jump onto the ectopics. First point, maybe it is a very small gestational sac due to late conception or due to some other reason which is not picked by that ultrasound. Why I say some other reason? Maybe that sonologist, that radiologist is having an old machine
Yes.
or less of experience. So whatever, it can be a pregnancy which is very small and is not picked by ultrasound. Point number second.
Yes.
Maybe now whenever a patient is coming with the ectopic, the classical symptoms, the bleeding PV is over there.
Yes, sir.
And why not a bleeding PV will be in a complete abortion?
Bilkul. There is,
Now,
it's
if
there.
this is a complete abortion, it will come with a report of empty uterine
Empty
cavity.
sac, yes.
Don't jump on to the ectopic. So the
Yes.
second possibility is complete abortion.
Yes.
So then, if you have ruled out that this is not a very small gestational sac which is not picked and it is not a complete, then only you have to think on lines of the
Ectopic
ectopics.
pregnancy. Yes.
So the basic important point is that you have to put your theory in action.
True. Yes.
Now, there are two things what we have to see over here. One is that this ectopic can be extrauterine or intrauterine. When I say intrauterine, I don't want to say that intrauterine normal, because intrauterine cervical ectopic is also intrauterine.
there, yes.
The coronals are also,
Also there.
ectopics, but they are intrauterine.
Yes, sir.
So there are two sets. One is extrauterine and intra. Now see,
Intra.
these points are very important to understand. A gynecologist, I mean.
Yes, because we at time we need to differentiate it.
Right. Now, for example, if there is a sac in the cervical canal and your radiologist is confining the scan onto the uterine
Uterus,
cavity
yes,
only,
it might be missed there.
might be missed. So you have to think. Now, if a patient is coming to you with the classical symptoms, the bleeding PV is there, secondary amenorrhea first, then there is
Pain
a
abdomen,
pain also. You are
pride is
thinking
there.
on lines of ectopic, but
Ectopic.
your radiologist is not giving you that report what you are expecting.
Expecting, yes,
But
sir. And
maybe,
it do happens. It do happens.
maybe it is intrauterine
Uterine
ectopic.
only. Yes.
When I say intrauterine, I mean maybe it is in cervix.
True.
Then, if that radiologist has scanned cervix properly, that means that
Okay.
everything
yeah.
is okay. But if there is no picture of cervix,
Cervix,
then you
yes.
can ask for. So that way, the radiologist should not start dictating you, madam, it is not this, it is that.
Yes, sir.
You will say him that maybe that you have missed the cervix.
Cervix. Yes.
So keep a note that extrauterine and intrauterine ectopics, bulk is of extrauterine.
But
I mean,
we do have intrauterine at times also.
intrauterine also.
Yes.
Now the point here is that sometimes there comes a report of of a plus minus sac.
Yes,
Now
sir.
see, when I say plus minus sac, I mean that there is a sac-like structure.
Like structure is
A
there.
report is coming to you that madam, there is a sac-like structure.
Query sac.
Query sac.
Yes, sir.
Now you have to take a decision. What to do, whether this is a sac or not.
We
Maybe,
should know what is,
yeah.
whether it is true sac or
Right.
pseudo sac.
Maybe that you are dealing with a pseudo gestational
Gestational
sac,
sac.
which is looking like a sac.
Yes.
Then you have to ask that radiologist or that whosoever is doing ultrasound, is there any unobliterated uterine cavity?
Yes. That is the feature which will be differentiating both of them.
Right. Now, when you will ask that radiologist whether there is any unobliterated uterine cavity, then he will get back to the pavilion,
Yes.
Open the books, how to see for that. And if he will see for the unobliterated uterine cavity, he will not put a query on the report.
Yes, sir.
It
This
is
true.
because of the unobliterated uterine
Uterine
cavity,
cavity.
which is not very clear with that person.
Yes.
That is why he is putting a query over
Query
there.
sac, yes.
Now you will make him to, do good things in future also. Now, if there is an unobliterated uterine cavity, 101%, not 100%, 101%, it is not a pseudogestational sac.
Yes, sir.
So these are the theoretical things which you have to, put in your brain. Then
This is a
only
very
you can
good
finalize a diagnosis.
Fine tip to differentiate both
Right.
of them.
So not all queries will come to you if you will ask that radiologist whether there is any unobliterated uterine cavity, because if there is no unobliterated uterine cavity, then you are dealing most probably with
the-
a pseudo-gestational sac.
And many times gynecologists are doing scan by themselves, and in early pregnancy scan, they are also having the same doubt whether it's a true sac or whether it's a false pseudo gestational sac. So we can differentiate it by unobliterated uterine cavity.
Unobliterated uterine cavity. So here is the example of a bucket with a water ball and the bucket without the water ball, that is the water. So we'll not elaborate these things because these things are will take time, but the basic important point is if there is no unobliterated uterine cavity, then you are dealing with north. I mean with the pseudo-gestational sac. So ask for the unobliterated uterine cavity.
And now we should look at the pictures also.
Pictures also. Why the radiologist is giving you picture? He is bound to give you pictures. Then you have to see yourself what is on picture.
Yes.
Now see over here. There is a picture which is given by maybe that radiologist, that sonologist, whosoever has done the ultrasound is not very clear with the unobliterated uterine cavity. Now see, here is the unobliterated uterine cavity. If that doctor has put a query onto this gestational sac, then that doctor need to send to the MBBS first year. Then he has to, go back to pavilion.
Because it is very clearly
because it is very clear over here that there is an unobliterated uterine cavity. So this is a true gestational sac.
Yes.
Now see, if there is a sac in which I don't have any unobliterated uterine cavity, that is going in favor of a pseudo-gestational sac.
True, sir, true.
Now see, if I will put a fluid, water in this hall, in this room, okay, what will be the shape of that fluid?
It will take the shape of...
it will be square or a rectangular like this.
Whatever the room is.
Whatever the room. But if this room is round, so the point here is that the property of fluid is that it will take the shape of that thing where it is.
Yes.
And over here, now see, these points are very important. Over here, it is there in uterine cavity. Where the uterine cavity is tapering?
Towards cervix.
Towards cervix. It means that this water
has to go toward
whatever over there, not water, actually fluid.
Fluid is there.
Whatever is there will taper towards cervix.
Cervical canal.
What is that called as?
Beak sign.
Beak sign. Now see, if you know that there is something which is called as beak sign, and if this comes as a query sac, then you will teach that radiologist, sir, madam, it is not query, there is a beak sign. It means that we are dealing with a pseudo-gestational sac.
True, sir, true.
Right?
Yes.
So these are the important points. These will come up when you are full with knowledge. Now see over here, this is the beak sign. Don't indulge in the fancy definitions, beak sign or these fancy things. This is tapering towards cervix. Cervix is this way.
Yes, sir.
Now this is a true intrauterine gestational sac which will not taper. And one more important thing is that where are these intrauterine sacs? Normal. Eccentric, not in center. But these fluid collections, these pseudo-gestational sac, where they will be? In center or towards
they are
the periphery?
Central because the fluid is in the center.
Right. Again, the gravity. Now see, the gravity, the fluid will go with the gravity. So gravitational point is somewhere in center when patient is lying on the bed.
True.
So that way it will be in center.
Center only.
So keep these things in your mind, then only you can make a perfect diagnosis or you can even rule out an ectopic. So there is something which is called as heterotrophic pregnancy also. By heterotrophic I mean one gestational sac normally placed and another is somewhere in the adnexa. Now if you are doctor, or even if you are doing a scan, you are confining your scan onto the uterus only, you are seeing a gestational sac, you are seeing a embryo with a yolk sac, with a fetal cord, you are getting happy, but you are missing the adnexa because there can be one here and another there. So if there is a case of ART case, don't miss your adnexa.
At times I have seen the reports in which they have given a very good picture of uterine cavity with a live embryo and the heartbeat is also there in the second picture, but adnexa are missing.
Adnexa, that is what I am saying. Don't miss an adnexa in case of an early pregnancy.
Yes.
Especially in these in these ARTs, there are chances of having a heterotrophic pregnancy. So this is a long discussion of this theoretical knowledge. If you are having a theoretical knowledge, these are, whenever you are Brain is full, then only your eyes can see.
Yes, sir. True.
So this is a short, panel discussion. Now I am having with me Dr. Sunita and Dr. Pragita. They will, throw more light on this panel discussion, whatever the topic is today. Maybe that they will be elaborating these ultrasound findings, or maybe that they will be asking, they will be discussing the beta HCG. So over to you. Maybe that you will get Dr. Sunita online.
Okay, sir. And now, as sir has touched a very nice thing about the scanning techniques and how to differentiate a true and false sacs, I'll be throwing some light on a very important factor that help you in making your decisions, and that is none other than beta HCG. The beta HCG is a very good friend of ours. Whenever we are stuck, we take help of it. So we should be having a small knowledge about its composition and how the levels are going on, and how we are making our diagnosis, and we are making it sure, yes, that we are dealing with a true, or we are dealing with a ectopic only. So I would like to start with this beta HCG part. But what is basically beta HCG? Beta HCG is basically a glycoprotein, and it is a glycoprotein hormone, and it is composed of two units. The two subunits are 2 alpha units and 2 beta units. So these alpha units these are non-specific one, and beta unit is very specific for pregnancy. And from where it is secreted? It is secreted by the syncytiotrophoblast, that developing thing, that the developing syncytiotrophoblast, the embryo, the outer layer is the syncytio one. So that is secreting this thing. So function of this beta HCG is mainly that it supports the corpus luteum, and it keep on stimulating it so that progesterone is secreted. And as all of us know, progesterone is a hormone of pregnancy. It helps in maintaining this pregnancy, and some small amount are also produced in other structure like in liver, pituitary gland, and colon. All you are also having this beta HCG, but our area of interest lies there for the pregnancy one. So we are more interested in that thing. So it is how we are diagnosing it, how we are making a diagnosis. We are doing beta HCG levels, we are taking levels in serum, and we are taking level in urine. So urine, the level come on later on when it is like around 20 or more than 20, then urine is able to pick it. In blood, you are using antibody, it's an ELISA test. So we are picking it early. It is very sensitive in blood. Blood can pick a level which is around 1 milli international unit. How this beta HCG is behaving? It has a very peculiar behavior when the patient is pregnant. It rises exponentially. So what is this exponential rise? It keeps on rising. It keeps on doubling basically every 48 hours, and this rises there till 8 to 10 weeks of pregnancy. So it reaches at around say at around 8 weeks, it reaches at its peak, which is continuing till 10 weeks, and then it starts falling with at around 16 weeks. This is a very good diagram which shows here the exponential rise of this beta HCG. You can very clearly see that when it is say around the sac is around say 4 week size gestational sac, then it starts rising. It's doubling every 48 hours. So, and say at around 8 to 10 weeks it is at peak, and then it keeps on falling. We are having a small secondary peak in this 32 weeks also, which is not significant. And so you should know that, okay, when we are labeling our patient, that we are labeling when the levels are more than 25, we are saying yes, that she is pregnant. Very important to know, when our beta HCG levels are around 1000, then you are picking it on a vaginal scan. And when these levels are 5000, you are picking it on abdominal scan. So this is very important, that these levels. And our management also depends on the beta HCG levels. So which patient you should take for conservative thing, which patient you should take for surgical thing. So for methotrexate therapy, whom we are taking are no intrauterine pregnancy should be there. Patient is stable, the patient is not bleeding, and hemodynamically stable, pulse rate and vitals are stable. Sac is unruptured and it is around say less than 35 millimeter, and fetal cardiac activity should be absent. and the patient is like willing for attending the follow-up session. If she is not willing, then we are not posting these patients for this thing. Single dose protocol, we have these protocols for these patients. You have to do your beta HCG on day 1, then you have to again do it on day 4, day 7, you have to do C. On day 1, you have to do the beta HCG, then you have to do the electrolytes, urine electrolytes, these are the LFT1, and then your blood group, which is very important, and then your complete blood count. This is the standard dose which you are taking, 1 milligram per meter square, and on day 4 you are again repeating the levels, on day 7 also you are repeating these levels. If the level decreases less than 15%, this is very important. If the decrease is less than 15% from day 4 to 7, then that means your therapy is not working nicely. And if it is decreasing more, then you are on the safer side. So this is how you are going to decide it. This is a very recent thing that I have come up with. So there is a beta HCG ratio. This is very important. They have done a study and they say that what they do is they take the level at 48 hours and then they divided it by the level which were initially there. If this ratio is less than 0.8, then your therapy is said to be successful. So the success rate was very good if this was there. Now I would like to invite other panelists over this same session so that they can also throw some light and what experiences they are having. So I would like to invite Dr. Sunita and Dr. Pragati. Hello, doctor. Hello, doctor. Doctor, yes. Doctor, I would like to ask about your experience.
I want to add on some things also to this, that according to even the latest RCOG guidelines, even there is a management in the form of an expectant management also.
Yes, doctor.
So we have an expectant medical management and in the surgical management. And in surgical management, we have the laparoscopic management and the open surgery.
Yes, doctor.
So it depends on the criteria we follow, isn't it?
Yes,
right?
yes.
And yes, definitely what you, as you said, the latest guidelines, they do say that if the fall is 15% is very much followed, and it's a very standardized protocol,
yes,
which we need to follow, and we need to, the basic thing is patient should be available for follow-up and should be ready for the follow-up also.
Yes, doctor.
And in our experience, definitely some of the patients, if we are not sure about the follow-up, we do admit these patients.
Yes,
that's
doctor.
what I want to add on to it.
Yes.
Rest all is, you have explained very nicely, madam.
Thank you, doctor. So now I would like to call Dr. Vani sir again. And sir, would you like to add anything more?
Look, I will repeat my previous statement that as you are having two eyes, you are seeing with your two eyes. When you are dealing with an ectopic pregnancy, you have to open up both of your eyes.
Yes, sir.
Not only ultrasound will make or exclude a diagnosis, your beta HCG will give you a 100% diagnosis with the ultrasound. And not only beta HCG will do, your one eye.
We have to combine both.
You have to combine both to make a diagnosis of an ectopic or to rule out ectopic. And before that, you should have a good theoretical knowledge.
True, sir.
Ultrasound is not about practicals.
True, sir.
Your eyes can see only what your brain is knowing. Unless and until you don't have a knowledge, you will not see. And don't allow that radiologist, whosoever is doing scan, to override you. He will dictate you.
True, sir.
He will say you, this is not this, this is that. So make him also aware that you know something, then only he will open up the books and he will upgrade himself. So that is all. Thank you, Dr. Sunita and Dr. Jyoti, and thank you everybody whosoever is has joined us online also. We are having, I am seeing there are multiple candidates because we are conducting it via YouTube and Zoom also. So we are conducting these types of panel discussions at regular intervals. We will be announcing our next panel discussion very soon.
Thank you,
very
sir.
much.
Thank you.